Good afternoon and welcome to everyone, particularly to those online, but also those particularly in the room as well. This is the Health and Overview Scrutiny Committee on the 31st of August 2022, taking place here at County Hall in the Spark and Ho Committee Room. Some of the officers instead are joining us via Teams, others are in the room with us. This meeting is being webcast, so can I remind you to turn off the microphones when you're not speaking, but also remember to turn them on when you are speaking. Likewise, for those joining online, please turn off your videos when you're not partaking on a particular item, but please do leave the video cameras on for the actual item that you're speaking on. So, I'm going to ask now for all of those present in the room, item 1, which is to do with the minutes of the meeting held on the 15th of June. Can I propose that the minutes of the meeting held are taken as read, confirmed and signed and agreed? Okay, thank you very much. Thank you. So item 2, question time. We have no questions from the public. So item 3, questions asked by members understanding order 7375. No questions have been received. Item 4, whether to advise of any other items which the chairman has decided to take as urgent elsewhere on the agenda. There are no other urgent items. Item 5, declarations of interest in respect of items on the agenda. So can I ask members, do you have any items or interests that you wish to raise? Bessie.
My daughter works for the NHS and I would just like to declare that she's no longer working for the Urgent Care Centre, but she's going to be an urgent commissioner. Yeah.
Okay, thank you very much. Are there any other items that anyone needs to raise? Oh, Councillor King.
Yeah, just in respect of item sorry, let's go to item 3. It's report 9. Yeah, member of the National Autistic Society.
So, I'm sorry.
Okay, thank you very much.
I'm sorry, I should have declared another interest, but I keep forgetting about my son. He's a mental health practitioner. Sorry, it's true. I have to declare.
Do you realise this is being webcast? So if he looks back, then he'll know that you've forgotten about him. So, okay, thank you very much for that. Any other interests? No other interests. Okay, thank you very much for that. We are now on to item 6, which is declarations of the party whip in accordance with overview and scrutiny procedure rule 16. Are there any declarations of party whip? No? Okay, that's good. So item 7, presentation of petitions. Understanding order 35, no petitions have been received. So we're now on to the main items of the meeting. We've got 3 main papers today. As usual, I'm going to ask for all of those who are holders of the papers. We have all read them. We have had a chance to digest them. So there's no need to represent any of the information, but by all means, I'll ask you to, if you wish to do a sort of couple of minutes summary before we actually start asking any questions or debating any of the issues, but we will take all papers as read. So we'll move on to item 8, which is the urgent and emergency care system. So Rachna, I can see you're here leading your team. We also have John Melbourne, who's the CEO of UHL, and also Rachel. No? Chris?
Yeah, my name is Chris West.
Sorry, apologies. Chris, very good to see you as well. So you're here from ITS. Is that right? Yes, absolutely. Okay, so Rachna, if I can go over to you first. And also, I think we also have John Wilson, who's Director of Adults and Communities, Leicestershire County Council, online as well. So I can see you up there, John, if there are any questions to do with adult and social care as well. So Rachna, over to you.
Thank you, Chair. So thank you for receiving the paper that you've got in front of you today. What it's effectively given you is a system update on what's happening from the urgent and emergency care pathway. So all the way from our self-care services, our preventative services, our GP services, community services, and of course our acute services and our local authority services working in partnership across what we call the urgent and emergency care pathway. What the report does effectively gives you the findings of the report that we've had recently from the Care Quality Commission. What they did, they came in and did a system review, which is the first time they've conducted a review across an entire system as opposed to an individual organisation. So it was a learning experience for both our system and for our CQC colleagues. Colleagues will be here talking to some of the specifics, but we have accepted the report in full and the findings. We have also augmented this with various different clinical reports. So we've had somebody called Dr. Ian Sturgis, who's an internationally acclaimed general physician who's been helping us to make sure that the plans that we've put into place will address the issues that have been outlined in the CQC report. And we've also had the emergency care intensive support team from the national and regional colleagues who have been equally looking at the plans to assure the fact that we have taken into account every finding that's taken in that CQC report. The assessments have come back as positive, that we've got every action taken into account. We now have to work together collaboratively across each healthcare organisation, each local authority organisation, and of course our patients, public and partners across public health to enact these and really evidence the impact that we're having on this urgent emergency care pathway, so that people are getting not only the right outcomes, but also a decent experience of care, which we are very, very cognizant of. Just a few things, Chair, if I may, to highlight from the report itself. It does really celebrate the dedication noted by all health and care staff, so not just NHS staff, but staff working in our local authority services as well, to support those patients outside of the acute trust. Things that this HOSC has looked at before, so the psychiatric liaison services in the A&E department, which we've known for quite some time have not been up to par. They've noted those as areas of particularly good practice, which is a real positive for us. And then equally, the report looks at how we treat our staff from a wellbeing perspective and highlights some real areas of good practice, given that the demand is not going to relent. We understand that, so we need to look after our staff no matter which part of the service they work in. There are, of course, a plethora of other things that we have to look at in terms of making things better. So our numbers of patients that we still have in hospital who are medically optimised for discharge, waiting for support outside of the acute trust, is of particular concern to us, and we continue to work with John and colleagues to make sure we can get those pathways as smooth as possible and to make sure we've got investment targeted into those services for a sustainable model and not a sticking plaster model. The last thing I'll highlight, Chair, is that we have a full system clinical quality summit on the 13th of September, which is effectively bringing partners together to look at the risk that is carried, particularly by our ambulance colleagues, when we can't reach somebody in the community in time, and what we are specifically going to do about those in those times to make sure that we can get out to those people who are waiting for a 999 ambulance. Finally, if I can just leave you with some areas of really good practice that we have picked up. We have got various things that we've already enacted, so we're not waiting for some of these actions to be put into place. So just this morning, I was at the Unscheduled Care Hub, which is over at one of our medical practices, where our EMAS colleagues, our DHU colleagues, our geriatrician and GP colleagues, LPT nurses, and Leicestershire County Council and Leicester City Council staff are all in the room, taking patients who have called 999 and are currently waiting for an ambulance off that stack. We are taking anywhere up to about 50 patients off that stack a day and keeping them well in the place that those patients call home, which is exactly what the CQC told us that we should be doing to make sure we spread risk, but also give those patients the best outcomes that we can. So some real shoots of improvement. We now need to sustain that, and we need to make sure we're prepared for winter and the increased demand that will place on all services across health and care. So I'll ask Chair, if okay, colleagues to come in if there's anything that I've missed.
Thank you. So firstly, thank you for inviting us today. And just to introduce myself, I'm John Melbourne. I'm the Chief Operating Officer at University Hospitals of Leicester. And firstly, I do want to acknowledge that we know that people are waiting for too long across both urgent and planned care at the moment in the NHS. And it is absolutely our top priority to improve things on both fronts there. We acknowledge and own the CQC's feedback on our services, and we know we need to improve in some areas. And I'm really sorry to anybody around the table that's waiting for their healthcare, be it planned or emergency, or indeed other people that are listening to that end. What I will say is some of this is a result of the pandemic, but some of it isn't actually. We've had many years of challenges in both planned and urgent and emergency care across Leicestershire, and we need to own that as well as a health system, but also as an organisation. We're working on a lot of things to improve things, and very simplistically, we chunk it into 3 pots. So firstly is flow into our hospital, which is about making sure that people present at the right place for care. And recently we've put in place a lot more capacity in both primary care and in our urgent care services. Secondly, in flow through our hospital, and we're doing things including increasing capacity in our hospitals to make sure that people can get into beds where they need them. And thirdly, flow out of our hospital. So that's making sure there's capacity to get people home, to get people to care home, to get people to communities as well. And again, within the last month, we've opened a new care home within Leicestershire, which again is a really exciting development for us. And we're planning more community beds within the next 2 to 3 weeks as well. So we're making big steps, but we recognise there's a long way to go to get where we want to get to where we want to go to. And I think it's a reflection of how we work that we recognise this is a challenge not just across UHL, but across the health and care system as well, which is why I speak to Rachna and John quite so often. Finally, again, thank you to you for your support in the process. But we know we're doing a lot. We've got a long way to go, and we absolutely recognise that.
Thank you very much. Crystal, was there anything else that you wanted to open? No, okay. So can I just open before I go for any questions, if that's okay? I just want to ask a couple of questions. So in the report, I think there is a date for one of the deadlines, which is actually tomorrow, 1st of September, which I think is referencing ambulance handover times. Given it is tomorrow, are you reasonably happy that has now actually been achieved or will be achieved, or where are you on that? That's just really the first opener.
So we were both very keen to answer, clearly. So we've had some significant improvements. So we've been having some really long delays that we've noted over the course of the last year. We have seen a direct reduction in those. Chair, we're not exactly where we need to be, but we're improving at a rate that we haven't seen before, and our EMAS colleagues are working with us on that specifically. The additional capacity that John referenced will help us to make sure that flow gets through, and that we can translate that then into making sure that we achieve that target. But I think we'll be hard pressed to find that the improvements that we have seen that we haven't seen before in this system.
Okay, so as far as that 1st September date, that's not going to happen.
That's right, Chair.
You got a revised date out of interest?
We have a trajectory that we've agreed with NHS England and our colleagues at the national team that we will continue to drive it down, and we will continue to look at doing all of this as soon as possible. It is really difficult to put an exact date on it because these things don't work on a parallel track of put X in and Y happens. It is a systemic problem that we need to deal with, and you'll know, Chair, it's many historic issues that we're trying to deal with here.
Okay, I appreciate that. Right. Okay. We'll probably come back to that one, maybe some of the others as well. Okay. Look, there were a number of hands up. I think I saw who was first? You were first. In which case, sorry. Okay, Bessie, I'm going to go for you first. Then I'm going to go to Phil. We've got literally everyone put their hands up. So okay.
There you go. The laptop's in the way. I have already declared an interest, but what I'm concerned about is the fact that there's a thread running through this, that there's not enough staff to care for patients and not enough staff with the
Thank you. I saw your light flashing, so I'll just repeat for the sake of others. So it's essentially, what are we doing around our vacancies across the piece? So firstly, I would say that workforce is our #1 risk as a health service. Absolutely. What we want to do is, firstly, we want to make sure that we're attracting all the types of professions across our services that we can, and that includes expanding into different areas, including allied health professionals, physicians associates, and different professions, to make sure that we can bring different types of skills to our services as well. We also want to become a better employer as UHL, and I know that's the case across the system as well. And that includes focusing on things, the basics like car parking, paying people correctly and on time. And I think by doing those things together of diversifying our workforce, but also being a better employer and a place where people want to come and work for us, I think we'll start to see progress. But as I say, it is our #1 risk, and I would be very surprised if I wasn't saying it's our #1 risk in 2-3 years' time.
I think it's something we should try and monitor to ensure that we do have the right number of staff at the right.
Without a doubt, this will be coming back. Absolutely. So, Mr. King first, then Mr. Harrison. Right.
Yes, thank you, Chairman. Thank you, Rachna and John. And the hesitation and the fact that I don't actually know who you are is actually, I think, one of the symptoms of a wider malaise, I think, with UHL. And I think the problem is there has been a very high turnover of senior executives in the last decade. We're now on our, I think, 3rd chief executive of UHL in, I think, 10 years, or just slightly over that. We've got a new board of directors. You've got an financially incoherent organisation. I appreciate that's not yourselves here that are responsible for that, but it is, you know, £400 million plus in deficit. We've got a set of accounts, Chair, that hasn't been signed off for 2 years. We've got the special task force in sorting out the financial mess that's been left there. And here we are with a report from CQC saying that the ED department was, or A&E as we like to call it, because I don't know what we're keen on Americanisms for that, is essentially not fit for purpose. And yes, I'm not doubting that there is a lot of very dedicated staff, very professional staff who are doing their best under the circumstances. But quite frankly, Chairman, this is not good enough for the people of Leicestershire. We spend an awful lot of taxpayers' money on the National Health Service. As the chair of the ICS said at a meeting, the Joint Health Scrutiny meeting a few weeks ago, £2 billion a year is spent on health across LLR. And this is just not good enough, Chairman, quite frankly. And I would have liked to have seen the action plan for improvements rather than just what the problems were 2 months ago. And to discover that one of the targets that was in this report isn't being met for tomorrow already. And yes, there's a trajectory, and I'm sure there is, but that's deeply concerning. And I think also deeply concerning that tens of millions of pounds has been spent on the existing ED department, because when a previous investigation was done, well, let's build a new department. That's the answer. It'll sort out a lot of our problems. And guess what? We've still got some of the same structural problems. And it is very, very concerning. And so I think, you know, I'm not trying to apportion blame here, but really some of this, it isn't about the pandemic. That's just exacerbated existing problems, existing structural issues that you've got. And what I'm not really understanding is, because we haven't got the action plan, is what is going to be done and how long this is, they think this is going to take, because we have had over many, many years, promises, pledges, action plans, you name it, to sort this out. And nothing so far seems to have got anywhere near it. And I'm not sure, obviously, without seeing it, yes, I'm sure you believe it's going to make a difference, but without seeing it and really testing the action plan and really scrutinising it, Chair, I'm not really sure. I've got a lot of confidence at the moment. I really do hope you can sort it out, but I am deeply concerned about this, as I'm sure you are as well. And yes, I can go through lots of questions about this, that, the other, about this report, but I think overall it isn't working properly. And I think this is, and the knock-on effect to the rest of the health and social care community in Leicestershire and Rutland is immense. Because if you don't get the front door right, the front door entry right for your most critically ill people, then the rest of the thing isn't going to work properly either. And I think this is where I am with it in my mind. I've thought about this quite a bit. So I'm not having a go. I'm just saying I think it is a much bigger issue than just the ED and just the fact there's a few ambulances waiting. That is actually symptomatic of a much bigger problem. And I don't think this report really addresses that. It's just focused on the CQC finding of urgent and emergency care, but actually it's a much, much bigger issue. Thank you, Chair.
So would anyone like to come back on any of those points?
So it wouldn't surprise you to know, actually, we agree with you. We agree that this is not good enough for our patients, and we are working relentlessly. Is it Councillor King? Sorry, I can't see your badge. To make things better. But on the flip side, I will tell you some nuggets of information which hopefully show you that we are heading in the right direction, and I'm more than happy to share the action plans should you so wish. So for many years, and Mike will back me up here, we've had one of the highest rates of unheralded ED attendances in the region. So this is where patients walk in without speaking to a clinician first. So with all the things that we've put in over the course of the last year, we've now got one of the lowest ED unheralded rates in the region, which is something that we haven't seen for the last 10 years. We have got the lowest EMAS conveyance rate into the trust, which is a real positive because we are seeing those patients in other services outside of the acute trust, which is the right place for them. They don't need acute care. Helps with what John was saying earlier about making sure we've got patients in the right place at the right time. We've got the highest referral rate in the region for services into our urgent community response. This is where our health and care teams provide a 2-hour response into people's own homes. So we've got a lot of things that are historic and systemic right, and we can prove that with a lot of the evidence. These are the bits now that we've got to fix to support the rest of the system. And I appreciate what you're saying about the pandemic, and it's not solely a response. We agree. As I said to you, some of these are systemic issues that we know we've had to deal with, hence why John's not here presenting this on his own, because this is a system problem, and you are absolutely right that the ED and the ambulance rates are a symptom and not the actual cause. So we are dealing with those causal issues. It will take us time to deal with them without just putting sticking plasters on. And Chair, as I said, I'm more than happy to share and go through action plans should you so wish.
Personally, I would like to see that, Chair.
Okay, I'm sure there'll be opportunity to bring back the item. That would be useful. John.
Thank you. So firstly, thank you for your feedback, and I'm sorry we've not met before now, Mr. King. So I'd be more than happy to have a longer discussion if useful. I'd just like to pick up 3 things. So you talked about the executive team finances and then the action plan. So yeah, I have only been enrolled for 6 months, and so I'm sorry we've not met before now. But as I say, the malaise you describe, I genuinely don't see across the executive team we've put in place at UHL. I think we have a pace, we have a drive, and we have an absolute ambition to put Leicester in a place where it should be from a healthcare perspective, and that is amongst the best in the country. Sorry, I can see from your face you might want to come back on that one, but absolutely I see that on a day-to-day basis.
Just if I may, Chair, probably not the current team, but previously. You know, we've been through so many teams. Understood. It's hard to keep up with who's doing what, quite frankly.
I think that, again, it's very difficult for me to comment on that, but what I will say is the team that's in place.
I'll give you the football analogy. If you have a football team, you change the manager so many times, your football team doesn't play very well. You can have the best players in the world, but then they don't play very well. So you need, if you keep changing the coaching staff, so you're the top people, you keep changing them, then eventually performance at the sharp end doesn't do as well.
I agree that I know our chief executive and chair would say the same, that sustainability of leadership is fundamental to successful organisations, and the most successful NHS organisations in the country have sustainable executive teams within there as well. And I believe that the team that we've put in place at UHL is that and can be that to drive this organisation forward. About finance, again, I think we've made huge progress in what we call our recovery support programme. Which is leading to the publishment of our latest accounts within the next 2 months. And again, this is cleaning. I appreciate this is addressing a problem from previously, but again, I see huge progress here. Truthfully, I don't recognise the 400 million deficit. It's not a figure I'm aware of. It's certainly not a position we ended last year with. So we're in a much stronger financial position at the moment, the end of last year and in this year. And I don't recognise the £400 million deficit you refer to in terms of our current position. The third point about the action plan, I think that's fair. We haven't presented a detailed action plan to you today. We'd be more than happy to do that. As I say, I think we've given a few examples of the progress that we're seeing and the actions we're putting in place. But I accept, clearly what you're saying is that what we've presented is not sufficient in terms of detailed actions, and we'd be happy to come back to address that. I think it is fair to say in certain areas we are seeing progress in our longest waiters. We've seen huge reductions in the last 6 months, going down from around 5,000 people who are at the potential of being over 140 waiters to nobody waiting for capacity reasons over 2 years by the end of July. So big progress in lots of areas, but I recognise there's still a huge amount of areas where it is not good enough for our patients and indeed our colleagues that we work with at the moment.
Just going to have Rachel is going to come back, and then I'll bring you Bessie in.
Just to augment the response that John gave, Councillor, we speak to each other more than I've ever spoken to any of my colleagues at UHL, if I can be perfectly honest with you, and the same with my LPT and my local authority colleagues. So whilst I appreciate everything you said about sustainability of leadership, that team that's going to deliver this are actually going towards the same vision and the same aim, which is where perhaps we've fallen down before. We've had different organisational aims as opposed to a system agreement of actually what we are going to achieve for our patients. It's making a huge difference in both the tenor of conversation that we have and how much we can hold each other to account before we come to committees like this.
Okay, thanks a lot. Betty, do you just want to quickly come in on this one?
Page 16, number D, it says high numbers of patients remain in hospital who are medically fit for discharge but remain in acute services. Can I ask, is there a disconnect between being in hospital and getting the right package for going home? Is this something because...
Yes, was that a different question completely? Because otherwise
No,
I've got
no.
Mr. Harrison coming in.
Sorry?
Otherwise I've got Mr. Harrison coming in. I thought that was related directly to this point.
No, it's go ahead.
Okay, if I could bring Mr. Harrison in, and okay, sorry, I thought this was directly related, but it's actually a different question. Mr. Harrison.
Thank you very much, Mr. Chairman. I'm concerned about the ambulances and what's happening. Last year, as chairman of this authority, I visited the chief executive of East Midlands. We discussed this at some length, and he said, well, look, last month we lost 15,000 hours with ambulances. I then went to meet the chief executive of UHL last year, had a discussion with him and the chairman of the authority, and I was beginning to see that, really, you need a 100-bed area with half a dozen nurses because it's crippling the whole system. We've got people, I know it was on the national last week, but somebody lying on a pavement for how many hours and somebody's putting a tent over them. I mean, it's outrageous. But if you're the critical bit and they can't get there because they're all busy doing something else, and I've been in a hospital and I've not met them to talk to them, but I could see these people wandering around having a coffee. They're just stranded. They're just in limbo. So half of that service is absolutely lost. I did discuss various bits, but ironically, we were halfway through the discussion, the three of us, and the phone rang and it was CQC is rather urgent, you'd have to take the call. So, and I'm just reading through it, obviously we know the history. But I am concerned because there doesn't seem to be a proper strategic thinking. If somebody can come and say, right, well, can you do this? Can you create an area to take people? Can you do something? They all thought it was good, but now they're probably not there, so who knows? But at the end of the day, we're not doing anything. We're just moving the deck chairs around the Titanic type of thing. And what I find is when you talk about real facts, bed availability, well, what are the beds? What are the staffing levels? How low are the staffing levels? What is the loss of staff? What is that gap? Are we short of 10 nurses or it's 210 nurses? We don't know. And you've heard from a previous member asking about, well, what are you doing about recruiting? And it was a lovely, normal, standard, smart reply. We're doing it, doing that. Fine. Strategic. What are you doing? Have you got a budget? Where are you marketing? Who are you talking to? Do you know how many nurses at what levels you need? why can't you tell me? Or can you tell me? Are you able to give me this is what we need to understand, because with lots of reports, not just yours, lots of reports come and they're all nice and padded and lovely jobs. But really, we want facts, numbers, understanding. You know, percentages can be misleading because a real number's better to know what we're doing. And what I'm saying is last year, if it was that bad, and we're now told it isn't, but then Richard from East Midlands isn't here to be able to say, Chief Executive, yeah, this is what we did last month in waiting. We don't know. And this thing is like a moving feast, but nobody gets to sit down and eat it. We never know what we're being served because it's moving around all the time. Now, I don't want to rain on your parade. I'd like to help, because that was my attitude. Why last year I wanted to find out facts, try and understand and make observations. So it's not that we're trying to be aggressive or horrible or any, but we're concerned because we collectively represent 700,000 people in the Shire. So that's a lump of people who we have to be accountable to. And when they ask us about what's happening on our policy, we don't know. We just don't know. So what we're getting told now is that it's improved. To what extent? You know, how many people, patients have you got on a daily basis? Is it 20 or 30 waiting ambulance? Is it 130? And what period is it? We've got to have much more understanding, because how can we monitor whether you're actually winning? I mean, you put the team out and it's lovely and, you know, and you're competent and confident, boom. But what is the data behind it? Is it real? Are you making progress? And when the chairman identified a key factor, you know, there's a task, there's a number. That's when we're going to announce this is what we're doing. And it's put back. And rationally saying, well, yeah, well, we're going to do that. We'll be doing that. We'll be looking at this. I mean, you know, once you start to lose those targets, you're beginning to slip down the hill. And trust me, normally the hills are like that. But the worse you are, it goes like that and boom, you're right at the bottom. So you may have time to dig in and try to climb back up again. But by not misleading, by just putting stuff together that doesn't really tell us what is the problem. We are scrutiny, so we're trying to scrutinise detail and facts. And, you know, there's no real detail in this to be able to hang anything on for us. And that's respectfully. That's not trying to be clever, because, as I said, we want to help. But we have to understand so we can help. And at the moment, I don't. Thank you, Mr. Chairman.
Anyone like to come back on some of those points? John, okay.
Yes, I'd like to, please. So, firstly, thank you for the feedback. And again, doesn't appear aggressive or whatever like that. It's helpful feedback, so thank you for it. And when you say you don't want to rain on the parade, I certainly hope that it doesn't appear that we're coming across with a parade today saying we fixed everything. Quite the opposite. We recognise there are big challenges that we need to face. In terms of the target for reduction or elimination of ambulance handovers, absolutely, ambulance handover delays, absolutely we want to get there. That is an objective which has been set by the national team. It is not a kind of, we've said we will deliver this by the 1st of September. We're trying to be realistic about what we think is achievable. We're putting in place interventions that will see progress. But what we weren't trying to say in the report is we will have zero by the 1st of September, because I don't think we would think that is where we are at as a system at the moment. The data around vacancies, etc., absolutely we have that. We have that across every single ward, every single area across our hospital, and we can happily share that. And again, I'm sorry that's not in the report. We'd be delighted to come back and share our vacancies by profession across all of our hospitals and indeed across all of our services across the system. We know that workforce is, as I've said earlier, the #1 risk for us. We talk about moving the deck chairs around. I genuinely don't think we're doing that. We're putting real additional capacity in areas, including in our ability to get people home and discharged, including opening the care home. I've talked about community beds, etc. We are putting in place additional capacity. Of course, we've got to juxtapose that with the staffing challenges that we're facing, and we're having that discussion every day. Would I love 100 additional beds? Absolutely, I'd love them today. It's not that simple, because for many reasons, workforce because of the capital required to build them, space, of course, on some of our sites as well, and timescales. So there's lots of factors around that. But we recognise by putting in place additional capacity in the right areas, but also the ability to get people home in the right areas as well, we can see progress. And finally, the point about if Richard was here, I think he'd recognise what we're saying actually from EMAS. We are not providing a good enough service as a system to EMAS at the minute. They are still having delays about their response times, and again, we own that, and we acknowledge that. And as I say, we speak to EMAS on a weekly basis as well about the challenges that we're facing.
So can I just ask a quick clarification? This particular report was obviously put together in the last 2 or 3 weeks, I'm assuming. Chris?
So the report was put together probably a month or so ago, actually, because it was for our other scrutiny committee over at City. So we've shared exactly the same report. So in truth, we could have updated it. So I hold my hand up and I apologise if you could have helped with a bit more information. I think the way we've tried to put it together was because actually, as we're hearing today, it's such a complex matter. So there are not 1 or 2 or 3 or 4 items that we need to fix in order to make the pathway and everybody's experience from the front door, emergency department, or indeed going home right. We all need to do a number of elements to simultaneously actually to make that pathway better. And I think when I first wrote that paper, I was trying to capture for you and my other colleagues at City that flavour of the amount of work that's going on in a really complex situation. And you're quite right. For some, they want all the detail. Others just need to understand the bigger picture and to know that, particularly my senior leads here, understand the challenge and are leading from the front. So that's why it looks the way it does. We were asked if we would come here, and it seemed appropriate. We shared exactly the same information.
So thanks a lot for that, Chris. Can I ask in that case, because I mean, I'm going to go back to the 1st of September in paragraph 20, because it is a very specific, I mean, it's about the only thing in the report that is a very specific target with a date attached, with a timescale measured, etc., etc., etc. What's happened in the last 4 weeks? If you wrote that 4 weeks ago as a very, very clear boxed, we've got a date, we've got a target, we're going to hit it, we're very confident. What's happened in 4 weeks for that not to happen?
So it's as explained. So the actual target was one that was set for us nationally. So it was very clear. And I'll go back to one of the comments that you picked up earlier, that actually the scrutiny of the plans, I think Rachna said it earlier, actually there's all plans that have been written, and the experts that have come in, which are listed, have come in and said, actually, you're in the right area, you're doing the right things, but actually one of the messages was, don't keep adding in new things to do, get the right things done and get the top things done, and you'll start to make a difference, which I believe is what we're now seeing. And actually, if you look back at when it was written, there were long waits, weren't there? We were in double figures. Some days we were at 20 ambulances waiting. And actually, with all of that good work, we're right back down to single figures now, and many days when we don't have any. So actually, when it was written at the peak of its concern, and with National Drive and all the good work that's already been done, there is improvement. You're quite right. The first we all wish we could sit here and say, do you know what, we're going to achieve it by tomorrow, but actually the good work is now having an impact, and people are not waiting now. Our ambulances being able to be released and able to get to those people who are waiting in the community sooner.
Okay, thank you. I think it's about having, I mean, with all the reports, it's about making sure that what you're telling us, you're confident of actually being able to achieve, because actually some of the commentary, I think, from Mr. King and Mr. Harrison, it's the issue is more about being told this is going to be resolved, this is going to happen, etc. And then we come a little bit further down the line and it doesn't happen. And it's about getting that confidence back into what you're saying.
Yes, I appreciate that. I would like to say that it was done in open and transparent. We were given that target, and it was not about hiding that target. the fact that we haven't achieved it at quite the level we would have wanted to do is about being open and transparent so that you can scrutinise the work that we're doing, as opposed to saying, actually, aren't we doing great, but we secretly know we didn't achieve a target that was set. So I don't do it to be, you know, just to set the scene as it was, and to share with you the same information we shared with our other scrutiny committee.
Okay, I think it's the theme rather than necessarily the
appreciate
specifics,
what
which
you're
I appreciate
talking
you
about.
understand as well. Actually, you're going to come back in on that point, and then I'm going to come back to Mr. Harrison.
Just from an assurance perspective, Chair, we are more than happy to come back with the specificity of the plans and the specifics that we have delivered over the course of the last couple of months. And I've just had a quick look back. When we started this programme, our average clinical handover for EMAS was 1 hour and 26 minutes. When I look at the last 21 days, that's the data I've got in front of me, we stand at 46 minutes. So you can see some measurable and continuous improvement down. There is variation in there, no doubt, but we are working hand in glove with our EMAS colleagues to make sure that we can measure specifically where we are seeing those improvements, and we do believe we've got the right actions. We just need to do them constantly and consistently all day, every day, across that entire pathway that we've talked about today, so we can evidence that further.
I think that sort of information gives a lot more confidence than statements that we know are not going to be achieved. So I appreciate that. Mr. Harrison.
Thank you, Mr. Chairman. My concern is that I understand you're trying to move forward, and there's a pathway you believe is the way to get to the top, to get to a good service provider provision. But without the staff, I'd have thought that's the key and most important thing. You know, if you're carrying a loss of whatever the number, and it's probably a fairly large number, how on earth are you ever going to achieve where you want to be without the proper staff? Because when you read through, you can see there's areas of weakness in this, and it's all about the staff. Every business is about the staff. You have to have leaders, but if you haven't got good, competent staff, you're going to fail. And then the public are at that end, that they're beginning to see it, they hear it, and they understand that somebody's doing this, and then they're going to try and do something to somebody else. Staff has got to be the most important thing, and I'd strongly urge you to look at a major campaign. You're nothing without the right staff. And none of these problems, in my mind, will go away until you've got all your teams there and you're fully staffed up. Then you can deal with things in a different light. You know, when you're running with one arm up your back, it's very hard. Thank you, Mr. Chairman.
Very brief comment. So I 100% agree with you as being a better employer, and as getting more colleagues into the organisation, and indeed retaining colleagues that work with us. We've seen increasing retirements over COVID, etc. Absolute top priority for us. Coming back to the recruitment campaigns you talk about, very happy to come back with lots more detail on that side of things. The other thing I'd say linked to that is I think it aligns with the financial challenge that we face as well. So we become more efficient with a consistent and fully staffed wards and services, and we are less reliant on other services such as insourcing and premium pay, etc., that we have to do to cover vacancies. So absolutely, it fits our challenge of quality, access, and indeed financial sustainability.
Okay, rationing on the comment as well.
Thank you, Chair. So just to add to that, it's not just health staff, remember. So we're also talking our social care staff, we're talking about our care home staff, and the staffing across that entire system, because actually we need to build this as a system. So it's not an individual recruitment campaign that we're looking at with just our UHL colleagues. It is a system-wide recruitment campaign to look at how do we bring people in across all of those health and care organisations, working very closely with John and his team from a social care perspective as well.
Okay, thank you very much. Now I've stacked a few people up, so I've got Betty coming back very briefly, then Mr. Hills, then Mr. King. Do I have any other hands up? No? Okay, we'll see how we go on that. Betty.
To some extent, you've covered some of it because you talked about the staff and the fact that I think you're going to give them the opportunity to actually improve services for local people. I'm looking under page 20 at 22, and you could talk about a multi-agency patient safety risk summit. Will we have any input into that summit as a council?
We have currently, I haven't got members of the council present, but you are more than welcome to join if somebody wishes to be part of it. What we are doing is we're working with our clinicians to understand twofold. Going back to the question of strategic direction, actually, we've got our strategic leaders who will be present from a clinical point of view across the system, and we will also be inviting our leaders from the front line, so that those individuals that will be present will be hearing what it feels like, not just from a patient and public or a user perspective, or indeed a carer, because as we know, watching is not nice either, but also we'll be hearing what it feels like to be on the front line, whether it's a member of staff from emergency department or our ambulance. And we're going to be working through, there's some grounds at some context setting, understanding what part of what we've talked about today and the journey we've been on. And then actually what we're going to be focusing on is really how do we start to make a difference on a day-to-day staff member, department and team direction. And it goes back to your workforce, a happy workforce, even though we might be short in numbers, if we work more efficiently together. So those are the things we're going to be working on together as a system, as opposed to individual organisations. So that's the plan at the moment. I'm more than happy if anybody wants to come back to me later and let me know if you wanted to be involved.
Okay, thank you very much. Yeah, we'll take that offline. Okay, thank you. Mr. Hills.
Thank you, Chair. If I could be a bit greedy, I've just got one question. I want to go through two scenarios with you. First question is fairly simple. A lot of the challenges that Leicester are facing won't be unique. You know, they'll be happening up and down the country. So what work is being done to look at other similar trusts and kind of what we're learning from best practice and what else is going on?
Fighting to answer that one. So we have various teams in from the national and regional teams, which are looking at systems that are similar to ours and suggesting to us, this is what you could do, this is what you could do based on the best practice. As I said, they've looked at the plans that we've got into place. They're confident that we've taken into account the best practice which suits our population, because of course you can't just pick up some of these solutions and pop them in, but where we can, we absolutely will. This week we attended a webinar about a process that's been put into place in North Bristol, which is directly looking at ambulance handovers. We've done the assessment between ourselves. What can we do? How quickly can we put things in place? And therefore, will it impact in the way that we think it will? So we are constantly looking at this and sharing best practice. The reason that a couple of our colleagues are not here today is because they're at a regional event, which is looking at specifically urgent emergency care flow, where we go, we listen to what other areas are doing, we bring it back, we assess it, and we see if it's something that we need to do. But the important thing is, whilst we do that, we are confident that we've got the right actions in place. As I said, sustainable, relentless focus on delivery of those, as opposed to constantly adding more and more things in. But absolutely, something we do. We do have the national team in and the regional teams in, both on the elective pathway and on the non-elective pathway, to support us with understanding what else it is that we can do.
Right, thank you for that. I do say a slight hesitation because I realise if you have too many processes on, then nothing ever gets done, does it? And sometimes just starting the to-do list, you know, is the most important thing. I actually got an email last week, very timely, from a resident of mine in Bolston, and he asked me to raise it at this meeting and when we discussed it. And he said, my 91-year-old wife fell in the garage, going to the freezer, and lay on the concrete floor for 20 minutes before I was able to find her. We phoned the ambulance and were told they were very busy and they'd get back to us as soon as possible. We then had to phone many times before we finally got a call out 8 hours later, and they're diagnosed with a broken hip. In the report, it says something I'm not familiar with, the Integrated Care Response Service, which is an innovative partnership which offers to get a call out within 2 hours, 24/7, 365 days a year. Could you talk a little bit more about that? Because, you know, people falling over and being on the floor for hours is not uncommon at all.
So we have something in the county which has just been launched, and I mean just, I think it's either today or yesterday, called the Integrated Falls Response Service, which is exactly for what you've just described. So in the city, we set this up a year or so ago and been piloting it to prove the efficacy. So it's a 2-hour response with lifting equipment, working with our EMAS colleagues and our geriatricians. They will pick up the patient if it's safe to do so, treat them in their own home. They will equally do the falls assessments at the same time, but as well as looking at, do they need grab rails and, you know, all the other assistive work work that could be done to the house to prevent a further fall. We don't have that service in the county, so that's what we're piloting again this week to look at whether we can use our DHU colleagues in the cars that we've got to support the very busy EMS service. So recognising that we've got it in one part of the system and not the other, we, as you said earlier, learning from what works in one area and making sure that we can fund it properly and sustainably across the entirety of Leicester, Leicestershire and Rutland, given the best practice that we've got in some areas.
So the pilot's going out right now, literally as we speak, for DHU. So when will that look to get implemented?
So I mean, it starts right now. So yes, I am. It started. So again, as part of the results that we bring back, if that's something of interest, I can either feed back individually to you, or I'm happy to bring it back to this to show you the evidence of it.
And my final scenario, if we're going to reduce the impact on the emergency department, we need the right people there at the right times. And, you know, I'd be interested to hear your thoughts on what percentage of patients turn up at the emergency department that shouldn't be there. You know, you played rugby, you sprained a wrist or an ankle, you've gotten drunk on a night out and you've fallen over and you cut yourself. You know, these aren't really emergency department things. In the report, it says about the urgent treatment centres that are opened up. Again, it's not particularly specific. It says they're open up to 12 hours a day. You know, well, how often are they usually open? You know, what's the average hours? Some of them have walk-in access, but then I presume not all of them do, if it says some of them. We spoke at the last committee meeting about how difficult it is to get in to see a GP. And again, you know, it's symptomatic of one part of the system is not quite working. You know, people can't get in to see their GPs, so they're going to turn up at the emergency department, unfortunately, when they shouldn't really be there. What has been done to increase the access to these urgent treatment centres?
So the urgent treatment centres themselves were commissioned by 3 different organisations. So I will start with that. There was Leicester City Clinical Commissioning Group, you'll remember. There was East Leicestershire and Rutland, and there was West Leicestershire. So we have a plethora of commissioning decisions to unpick and recommission effectively, which is the strategic review that we're doing at the moment, wholly recognising that if people don't know what's open, they will go to what they do know, what is open, which is our emergency department. So that's the work that's ongoing at the moment. What I will say is an urgent treatment centre is very different to GP access. So we do need to start working with our patient, with our population to make people understand where to go for what, which I appreciate is a very difficult thing if your literacy is not great, or quite simply you just want somebody to see you. So we need to make sure we've got a no wrong door policy. So when a patient goes in, they get seen, they get treated, they get the access that they need. So that strategic review is ongoing, and we expect that we should have some sort of standardisation. The issue that I've got at the moment, and I'll be very frank, is I'm not sure we need the standardisation of everything open at all hours of the day, because quite frankly, we haven't got the staff to do that. And the second thing is that the need is not there. So I've got services open at the moment out in the county which are not used anywhere near full capacity, but I've got an emergency department which is full. So we need to figure out why that is and how we can make sure that those services are used properly and those services the demand on those services are reduced. That's a piece of work that is systemic across this across this patch because of those 3 individual commissioning organisations. Now we've got it into one, we've got a real opportunity to right size it and to make sure it's fit for purpose in terms of asking each of our patient cohorts and populations, if you've got this scenario, do you know where to go? Similar to what you've just said, because we need to make it easy, we need to make it simple, and we need to see these people where they present.
Going back to the start of my question though, you know, do you think there is a problem with people turning up to the emergency department when they shouldn't be there? You know, is that a big issue or is it not? Because you said, you know, the urgent treatment centres are empty whereas the emergency department's full. That's fine if all of the emergency department problems are emergencies.
So to clarify, urgent treatment centres are not empty. They're just not fully utilised. So it's a really clear distinction that we just need to make sure that we've got 95%, 100% utilisation, because there's capacity sitting there that could help our emergency department.
So yes, people do present at our emergency department that could present better elsewhere across the system. Every emergency department in the country would say that, but the audits that we've done over the last 2 or 3 months suggest anywhere between 10 and 25% of patients presenting ED could have their care better treated elsewhere. Just the second point to say, I'm really sorry for the experience of your constituent, and I hope they got good care once they got to the hospital. But any issues again, please let us know.
That's pretty good.
Good. We aim for within 48 hours, so that's good that they've got that. Thank you.
Okay, thank you very much. So Mr. Charlesworth is going to be the final question in that case. So it's Mr. King followed by Mr. Charlesworth. Mr. King.
Yeah, thanks, Chairman. So just to pick up the last point you were just mentioning there, Rachel, Rakshna, sorry, about the county urgent treatment centres. And I've got one of those in Market Harborough, which isn't used terribly much. And there's two reasons for that. One, there's no X-ray machine that operates outside of Monday to Friday between after 4:45, because you don't have a service that operates. And secondly, because it's been messed around so much over the years, residents have given up using it because they never know. And as you will know also, the service operator last year decided to close it, unbeknown to anybody, at weekends. They decided to close it in the afternoon when they perhaps didn't have enough staff. I don't really know why, but we never really got to the bottom of that. But there's lots of historic reasons, unfortunately, and because there's been confusion of, well, is it open, isn't it? Might have a broken arm. Well, I don't bother going there because they haven't got an X-ray machine, which everybody knows. I'll go to the Royal, or I'll go to Kettering, or whatever, and that's a problem. So you've got, it all comes back to taxpayer. At the end of the day, taxpayers are also the patients, and it's about our confidence in you as management to operate the systems that you've got. And you know, we've got a report here which is pretty damning. You know, there are lots of things in it which are not good. It's recent and more, you know, as you've said, more embedded, more structural, which you need to sort out. And we've been here before. I'll repeat, Chairman, we've been here before. I was on the Health and Wellbeing Board for 2 years before that. We had, you know, got raised there about performance, and it's been raised time and time again that, you know, and we've been promised it's all going to get sorted out. So what I would like to say, coming back to this action plan, that's great. But what and picking up the chairman's point about this thing for tomorrow, which isn't being met. So when are we going to know that what the action plan that you're working on is working? When are we going to know that you've got a sustained, it's not just a flash in the pan improvement that because X is here, Y is happening, and as soon as X leaves, it'll all go back to where it was before, because that's not what the people, taxpayers of Leicester, Leicestershire and Rutland want to see. They want to see a improved, sustained, long term. They don't want to see these problems again because we've been here for too long, and you know, we can't carry on like this. So I think, Chairman, it is that serious. So we've got to see some market improvement, but also when is the time scale? When are you going to be able to come back to say, right, here we are 5 years later, this is carried on? You know, I probably won't even be on the council then, who knows? But the point is, we've got to have that level of confidence that we've got a long-term plan that's going to fix this, not just it's for the next financial year. Thank you, Chairman.
So I couldn't disagree with any of that. As you'd expect, everything that you've just said in terms of making sure that we have got some very clear metrics so that we can look at not only inputs, because we're very good in the NHS at measuring inputs, but not so good at measuring the outputs and impact and what that has on a trajectory perspective. So every line of our action plan, as John says, we've got it in 3 buckets: how we manage demand, how we manage flow, and how we manage outflow. Every single one of those has got a metric, which is an input metric. So how many staff, how many people per hour, so on and so forth, and output metrics. What impact is that going to have on the big targets that we've got to hit from an NHS standards perspective and you know, a public health standards perspective and an adult social care perspective? So we've taken all of that into account. So again, happy to share some of those. Those trajectories have been agreed across the collaboratives. So we've got those. So it's not an individual organisation saying we're going to deliver this. The key point you made is sustainability. So it's very, very easy to put in sticking plasters, which could solve some of these problems tomorrow. Unpalatable sticking plasters, but they'd be sticking plasters. So we have chosen deliberately not to do that, like some other systems have, and we have chosen to look at addressing those systemic and historic problems that we've known that this system has faced. We're committed to doing that. So we are happy to bring back those trajectories and the plan, as I've said, to make sure that you've got the assurance that you seek on some of that incremental improvement. I've given you a couple of examples of where we've seen those improvements already. So the conveyance rate for EMAS, I will continue to talk about it. It's, as I said, lowest now in the region. We're taking anywhere between 30 and 50 patients off that EMAS stack every single day and putting them into an urgent crisis response service. We are So we've got the ambulance handover delay trajectory, which I explained to you, 46 minutes over the last 21 days. You know, we've got some real measurables to show improvement, and that should give us hope actually that we're working in the way that we are working. We will change things, and we will change things sustainably, and not, as you say, a flash in the pan so that we can. It's not sustainable because we've chosen to put a sticking plaster instead of dealing with the actual problem itself.
Thank you very much. Okay, final question we've got to Mr. Charlesworth.
Well, it is a question, but a bit more than that. I may have should have declared this, but my stepdaughter works at a surgery in the city, which is by appointment only, and there's only one doctor over on there. I think that's DHU run. I'm not going to mention the name, but she says many people choose, because of the locality, to go to A&E instead of a GP because it's easy. Because of the locale, they can just walk 500 yards and they're in A&E, and that's easy because they ring up for an appointment. An appointment is many days away or weeks, so they do the easy thing. I don't blame them, it's human nature, but that presents a problem for you, and it's that triaging of that. And you're right, there's a big cultural thing in the city about people understanding where to go for what the condition is, and they choose the easy option. I mean, I can give you an experience. I was out campaigning once and got bitten by a dog. I phoned my GP up saying, you know, I've been bitten, flesh is torn, nails off, and I thought they would deal with it. They said, no, you need to go to A&E because you'll need a tetanus. So I went to A&E, spent many hours in there. I wasn't urgent, and I kept being pushed back, and I understood why. There were more urgent issues coming up, but in the end they couldn't do the tetanus there, and I had to go back to the GP for it. So the joined up working and thinking wasn't there for that particular instance. But as a word of encouragement, I think your staff do a wonderful job. The experiences that I have had personally down there have been fine. I've known the situation. Funding, buildings, lack of staff. I won't mention Brexit, but they're all problems that are not to do with the staff that are currently there. As far as I'm concerned, they do a difficult job very well. So I would encourage them to keep going, as hard as this winter's apparently going to be. I think they do a good job. My experiences have been okay. Nobody wants to go there, but I do think dealing with people you mentioned triage in the paper, but there's got to be a really effective way of channeling people to where they need to be, and those services have then got to be there.
Thank you. So really helpful points. So firstly, the location of the ED. Absolutely, I recognise everything you say there. We have to put plans in place allowing for that, because we're not going to move the ED, let's be honest about it. So actually we need to say, well, this is the situation, this is the risk of it, and this is therefore what we need to put in place, including our minor injuries units and other services around the city. We do also have a real planned care challenge. We've got over 100,000 people waiting for planned care across Leicester as well. And so it is not a case where we can say we're going to stop planned care to look after our emergency care. We need to do both, and we absolutely recognise that. And it is, look, this is not me trying to shroud wave at all. It is the most challenging time in emergency care in the NHS for at least the last 20 years. And that's why the scale of interventions that we're putting in place are bigger than they have been. That said, I think what we've got on the list at the minute, it is a lot, but we need to do more. And that's what we're trying to present here. So thank you.
Okay, thank you very much. Okay, look, we're through the questions through the paper. So really useful, I think probably useful from both sides to hear some of the sort of frustrations and comments on, you know, what's going well and what's maybe seen as being longer term structural issues, and it's very helpful for the three of you to be able to sort of say, yep, we understand that, and we don't disagree. There are huge challenges. I think again, the perception I think from all of us is that we'd love to see more detail, because you know, understanding some of the numbers, some of the challenges, you know, appreciate sometimes deadlines are really difficult to hit, but you know, be bold, but at least be realistic, and give us comfort that you're all heading in the right direction. That the you know, the confidence that you have can then be shared by us as well, I think would be really helpful. So if you're happy to come back, probably be post Christmas now, I suspect, with a bit more information and where you've got to through the Christmas period, through the winter period. I think that would be really helpful for us, and hopefully give you an opportunity to share some of the success stories that hopefully you're ambitious for as well. Okay, look, thank you very much, Rachna, John and Chris, for helping us today. Thank you. Okay, we're going to move on now to item 9, which is the Learning from Deaths of People with Learning Disability and Autistic People Review Programme Annual Report. We've got joining us, there we go, we've got David Williams, who's the Group Director of Strategy and Partnerships at the LPT, and also, do we have Heather on line as well? Yes, Heather, I can see your picture there. There you go. So we've got Heather Pick, who's the Assistant Director, Adults and Communities here at LCC. So we will take the paper as read on the basis that we've had a good opportunity to read through it and discuss it, some of the questions. But if you'd like to take a couple of minutes just to give a sort of a very brief executive summary, or update us on any points that possibly aren't included in the report, and then we'll go into general discussion and questions to you on the report itself. So I don't know, between the two of you, which one would like to start first? David, you're off mute, so I'm assuming that means you want to go first.
Yeah,
Okay.
Can do. Is that okay, Heather? Yep, fine. Okay, great, thank you. So I think the key bits I just wanted to highlight were that actually this is Leicestershire County Council with Rutland and the city and the NHS working together to have a look at how we can do things, and we've reflected that in the leadership with Heather and I steering and taking the work forward. LEADER is the learning from deaths reviews that we support with everybody from who dies with a learning disability and now moving into autism. And this year is the 3rd consecutive year of doing this. So in this 3rd year, we're seeing an increase in life expectancy for those with a learning disability and autism. I think that's a good and positive place to be. I guess I'm holding on to the fact that we've got 3 years worth of data now, and actually seeing that establish over many years will give us something that's statistically relevant. The bit that I was just going to touch on today is I think there's a real call to action that we've tried to set out in the report about how different services can provide and support things. I think everything is really coming down to people making sure that in whichever service they're doing, they're delivering the basics really well and linking things together. So for community care, it's working together. It's helping the local authorities, the NHS and our care providers make sure that we're all thinking about the needs of the individuals that are living in our communities, that we're sharing information, and that we're supporting everybody to look after both the healthcare needs and the social care needs. And the more we drive of that, the more we'll support people to reduce the gap between the age at which somebody with a learning disability or autism in the county dies and the age that everybody else in the county dies at. So if we can do that, we'll improve life expectancy. So the report sets that out. Heather, if there's anything you'd like to add, please jump in.
Yes, I think through the years that we've been involved with the leader, it's been apparent that people with learning disabilities and now people with learning disabilities and or autism may not have the same opportunity to get regular health checks. And when they do, they may not be in front of a professional who recognises that they have special needs and needs for understanding properly the consequences of some of the health actions that they need to take. So I think the leader review has helped us enormously understand how to bridge that gap and how to make sure through our annual health checks that people are able to access routine screening and diagnosis that maybe because of their lack of understanding or communication skills, they wouldn't normally be representing at without some encouragement from health professionals. So a big plea then that to recognise that people with learning disabilities and or autism may need some special adjustments in their consultations, etc., but also some encouragement because there is reluctance to present themselves for screening. And I think that is the responsibility of all of us to ensure that they get equal opportunity and access to healthcare. Thanks, David.
Okay, thank you very much, Heather. Thank you very much, David. Can I start by asking a question? I can see hands going up already, but if I can ask a quick question. So obviously the report has a summary of, I think it's 77 cases that have come together that you've tried to extrapolate some sort of core information around. I mean, I can hear from the comments from Heather in particular, but also from David, obviously, there's real willingness for people to actually come forward and identify to give you a better feel for the issues affecting that particular group and understanding some of the statistics that you're trying to measure at the same time. That 77 clearly is sort of woefully low figure in the sense of it doesn't represent, I suspect, probably the whole of the sort of cohort that you're looking at. Do you have a feeling as to what sort of number you want to try and actually collect and to really give you a really clear view as to how accurate some of the information is that you're trying to analyse and then assess from?
Thank you. So probably a question for me in terms of picking things up. So the measure that we use to identify the individuals who will be eligible for a leader review are those people who are identified as having a learning disability and autism on the GP register. I think during this meeting, I'll probably give you the total number of people across LLR who are on the GP register with a learning disability and autism. I can't remember it off the top of my head, and it'll only take me a moment to look up, but that 77 deaths are all of the deaths across LLR for the patients who have been recorded with a learning disability and autism by the GPs. We think we've got a correct analysis of the number of people being recorded and reported by GPs, and we continue to keep that kind of under a watch. So the 77 feels about right for where we are.
So can I just ask, because the report also highlights the difficulty of trying to identify autism in particular, and for people to actually identify. So it was really as much as anything that part of it which I was trying and understand.
So it will be a formal health diagnosis. We'll get a box ticked on the individual patient record. So there'll be a spectrum of people. So people who've been formally diagnosed will be reported. People who haven't been formally diagnosed won't be.
Apologies, Heather. I was going to cut you off a little bit. Apologies.
Yes, I was going to say that the probably most difficult cohort is the autism only. It's very difficult diagnosis-wise and to capture within our systems. But for assurance in the county, we have a monthly update of deaths reported. And I know that our principal social worker scrutinises that, and if those deaths haven't been reported through the leader process, they're fed in. So we're fairly confident that the deaths we know about do get reported in and are put forward for review.
Okay, that's very helpful to know. Thank you very much. Betty, do you want to go first?
I think in a sense I've been answered, because my question really was around in terms of people presenting and not wanting to say that they have difficulties. I mean, how do you get over that stumbling block?
Thank you. I think a lot of it's about working very carefully and supportively with people and actually talking to them. We have primary care liaison nurses who work with the general practices to support and encourage people. We've also got people in supported housing, supported living accommodation, ways of working with their care providers, working with families. I think the other thing that works really quite well is talking to the county's partnership board, which brings together families and carers who also talk positively about supporting people. So people can be very nervous about coming to healthcare for services. We've done a lot of work around really bringing people for their COVID vaccines. And I think, you know, honestly, it's about having individual personal conversations with people about the benefits of coming and having an annual health check, which will support them, which will take them forward, which the rest of us, depending on our age, wouldn't be accessing. So it's a positive step of receiving for people that they can receive.
It's just a quick one. I mean, often going into GP surgery, it can be quite intimidating. And if somebody has learning difficulties in one thing or another, they may not feel comfortable in that environment. I know if I go into the surgery, I know the people there, but quite often it's that first step going into.
Absolutely. Looking at Heather and I, we've just lost a little bit of sound there. We definitely heard you say going in.
It's me.
Okay,
the point I'm trying to make is going into surgery can be intimidating, especially if you're supposed to be logging on one of those little computerized screens, and people with learning difficulties are not always au fait with these systems, and they stand there, and I actually think it does militate against them moving forward and asking for help and support. Don't know what can be done, but they're not the most welcoming places to go into for people, with most people, but people with learning difficulties in particular. Thank you.
I think it's a really, really useful question, and a really important one, in that there's two things that we're working really hard to balance. And the first is everybody is entitled to primary care in their local practice, and we want every single person to be able to access that. And that's the best way of doing it. We don't want to be in a position where actually people who with greater needs are taken into a different way of accessing care, because they should be able to access care in exactly the same way as everybody else. So we focus on that, but also with the ability to tailor and do individual support. So people like our primary care liaison nurses will accompany people to appointments. We'll work with, if they're living in supported living accommodation and so on, we'll work with the providers of that to help bring them there, work things through, practice with people. And we have also taken people on a gradual process of supporting stuff. So there have been supporting people who will come in a car outside of practice, or come in a car outside a COVID vaccination centre, but are too frightened to come in. And actually the nurses have adapted and changed the policies and given people vaccinations in the car and other ways of working. So you're taking people on a journey where they become accustomed to coming, and over time they'll become more understanding, more familiar with the environment.
Thank you very much. Mr. King, I think.
Yeah, thank you, Chairman. So I think just picking up the point you made earlier, it's a very small number of cases to look at and then extrapolate how we can improve healthcare and access to healthcare, as David just outlined there, which obviously we'd all like to see. So it will be useful to have the overall picture in the terms of the numbers of people who are registered with their GPs as having a learning disability and being on the autistic spectrum. And that brings me to my sort of substantial point, Chairman, in that people who obviously have visible learning disability, or perhaps who have very severe autistic impacts, that's very obvious to, and that can be very obvious to healthcare professionals and to society at large. But actually there's a very large cohort of people who, they're invisible. It's not obvious they have a disability, that they have autism, that they have a learning disability necessarily. They don't have a big sign on their head saying, I've got a disability, do they? And I'm not really sure how this review process is really helping, improve healthcare, access to healthcare for those people, because with improved diagnosis and everything else, I think I'm kind of thinking there is a growing group, a larger group of people in that group, and they may have all sorts of occupations and that they're undertaking from very on the surface, but actually picking up Mrs. Newton's point about people being worried about and being having anxiety about going and accessing healthcare, even ringing up a doctor's surgery to get an appointment, even acknowledging that they have a problem. Now, the issue, what you just mentioned, David, is you said that you've got specialist nurses that support people. Well, that's great if they're on your books, but if they're not on your books because they've been discharged when they get to become an adult, then, and if they don't recognise that they have a problem, then it is a bit challenging, isn't it? So I'm just wondering, how's this review helping to deal with that kind of segment of this population group? If you can explain that to me, thank you.
Yeah, not a problem. 4,530 is the number of people across LLR registered with learning disability or autism who are over the age of 14. So in terms of where we're going, I think what I'd say to you, it's ignore and forget the idea of LPT having patients on our books or ways of working. Primary care liaison nurses exist to support all of our practices, delivering really good primary care to people with a learning disability. So wherever people are talking about services being welcome, our primary care liaison nurses will go. What difference does it make? I think I'd reflect on twofold difference. So the first one is 3 years ago, we wouldn't have had a conversation like this in an Oversight and Scrutiny Committee meeting. I wouldn't have gone to, at the time, the CCG public board meeting and talked about actually inequalities for people and how people in LLR were dying at an earlier age just because of learning disabilities and autism. And we're now actually regularly having those conversations. And that leads to a really big change in the way we deliver services and the way we think things through. I get the opportunity of then taking this report and sharing it with local primary care doctors, GPs, PCN leads, and all of those people. And actually that starts a really big conversation about how do we make sure that practices deliver and meet the needs for people who find it harder to access services. That doesn't just benefit people with a learning disability and autism. That's about everybody thinking about how do we make a difference. So I think even at a simple level of us spending time talking about it, it delivers change and it helps make things happen. But the annual health check is something that, given my age, I'm not entitled to. I don't have long-term conditions. I'm on a 5-year annual health check cycle. By supporting vulnerable people to have an annual health check and learning everything from those who do die, we will improve services. So I do think it's a good thing that makes a difference.
Okay, thank you very much. Okay, I'm looking around. I don't think we've got any further questions. So Heather and David, thank you very much for that. I mean, it is, I mean, you're taking your points, David, about, you know, what would have been discussed 3 years ago and what wouldn't have been discussed. I mean, this paper, you know, it is new to us as a scrutiny body. We discussed it previously before the meeting, but also you've heard from some of the questioners today. I mean, there genuinely is a interest in actually knowing some of the background, the effect it will have, Bess's comments about access, etc., and also Mr. King's comments as well. I mean, it is very, very relevant. Interesting to know the total figure for those across the whole of the county area. But you know, to actually just understand how some of the data is going to be used, hopefully in the future, to affect service delivery, I think is really, really important. And it's one of those rare things where you can actually see sort of the sort of, we're almost at a point of actually seeing genuine sort of change happening because of what we're actually doing at the moment. So that's really, really positive. So thank you very, very much for that. So we don't have any other further questions. So thank you very much for your time with us today. And we look forward to seeing you hopefully in the future at a future session. Okay, thank you very much. Thank you. So we now move on to item 10, which is the alcohol misuse and trading standards. So we have with us Joshna, who's our public health consultant here, and her assistant, Mike Sandys, who's also joining us as Director of Public Health. So, as ever, we take the report as read. But by all means, if you'd like to give us a sort of an executive summary for a couple of minutes, or update the report from since it's been published, that would be really helpful, and then we can ask questions and open the debate. Over to you, Joshna.
Thank you. Good afternoon, everyone. So my name's Joshna. I'm a consultant in public health based here at the County Council. This report originally came about through a member query on underage sales and the work of trading standards in relation to alcohol. But as you'll see from the report, it's much broader than that. I wanted to focus on alcohol misuse as a whole and the work that we're doing and to try and capture that, because it is much bigger than the work of trading standards. So the report covers the evidence around the harmful effects of alcohol, the economic burden, and yet what we're finding is that the evidence suggests that only 20% of dependent drinkers are currently accessing treatment. So we've got 80% of unmet need out there. And the pandemic's exacerbated this. What we found is that the heaviest drinkers are drinking more, even more than they were originally. And as a result, we've seen across England, we've seen an increase of alcohol-specific deaths by 20%. Now, locally for Leicestershire, we've not seen that. We've seen that our rates, hospital admission rates, for example, for alcohol-specific conditions are better than regional or lower than regional national averages. We've seen our deaths are similar, and we've seen that our proportion of individuals successfully completing treatment is also significantly better than regional and national averages. And a lot of this success is predominantly down to the breadth of the service provision that we offer, coupled with our long history of partnership working predominantly with the police as an example. So it's a condition of the public health grant for local authorities to provide an accessible drug and alcohol treatment and recovery system. Locally for us, that's provided by Turning Point, and in the report I've listed the individual services that they provide within that offer. They also provide a dual diagnosis service, so that's specialist interventions for individuals who have co-occurring alcohol, substance misuse issues and mental health. And what we found from local data is that 68% of individuals presenting to the service have a mental health treatment need. So having that service has been quite crucial to the work that's done, so that they're not treated for substance misuse here and mental health in a different place. This is a pilot service that was originally funded by the CCGs. The funding's due to end at the end of March of next year, and we've not been told as of yet whether this will continue. We are pursuing that. We are advocating that it does continue, but the funding is coming from elsewhere. So we're sort of going to all the meetings that we can do to put the case forward on the success of the service. Turning Point are also piloting a provision looking at reducing the number of individuals who are at risk of the long-term effects of alcohol misuse. So that provision is doing a liver scan to assess early signs of liver damage. What we find is that individuals with alcohol misuse, the signs of liver damage appear first before symptoms. So if we can pick it up on the liver damage first, we can act quicker. So the idea is that we identify those individuals early, and then we support them to reduce their alcohol consumption. And one of the strengths of that offer is that it can be done as an outreach provision. So it can be done in primary care services, for example, rather than in the Turning Point service itself. So that helps with those individuals who are not yet in treatment, rather than waiting for them to be in treatment before you do a scan. In terms of what the Public Health Department funds, we've got alcohol brief intervention training. So there's 2 different types of training sessions that we offer, which I've described in the report. We also fund a Healthy Schools programme that supports all schools across Leicestershire. And the main bulk around substance misuse is focusing on providing resources to support schools in delivering drug and alcohol education. And then in addition to all of that, Leicestershire Police have a substance misuse team who provide quite an extensive offer, which again I've described in the report. And one of the key elements of that in terms of the partnership approach is that they jointly chair the LLR Substance Misuse Community Safety Partnership meeting alongside Turning Point. And what that does is it gives an opportunity across LLR to coordinate partnership activities. So our comms campaigns, any intelligence sharing, any issues around drug alerts, if there's anything, any concerns around contamination, etc. We have that joint approach. As the original ask was to focus on the role of trading standards, the penultimate section in the report just focus specifically on this. The way that trading standards respond is that when they receive a complaint around underage sales of alcohol, their response is reactive, so they're waiting on that complaint. They can then pursue a suite of options, so that could include visiting the premises and offering advice to the licence holder. They can conduct a review of the licence and then subsequently revoke the licence. They can issue a warning, caution or prosecution. At present, there isn't capacity within the team to conduct test purchases proactively, so that's not happening. Also in the report, the last section, I've talked about future developments, and there are quite a lot in that report. So as part of the NHS long-term plan, we're one of the areas that's received funding to set up hospital alcohol care teams, and Leicester City Council are leading on that on behalf of LLR. And that's twofold, the support. So the offer is providing specialist interventions to alcohol dependent patients in hospital, but also to liaise with the community treatment service to make sure that the ongoing support is provided on discharge. And again, that's something that we've been waiting for quite a long time and been pushing for. So we're quite pleased to have had that. That's not been set up yet, and we're still waiting for timelines as to when that will be implemented. So that's kind of watch this space. Also, the Public Health Department here is leading on the implementation of an LLR drug and alcohol death review panel. So this is a multi-agency panel looking at aiming to prevent and or reduce future alcohol and drug related deaths, and we're hoping that we'll go live later this year with that panel. We've been working on that with police, the coroner's office, etc. And then alongside that, we've received funding from the Office for Health Improvement and Disparities, OHID, to enhance our substance misuse provision, and I've included in the report the areas of work that we're wanting to focus on in the first year. So that's been submitted and approved, and we're looking to implement a lot of those services this year. Also looking to strengthen our input into alcohol licensing applications. We do, Public Health do have a remit in responding to those if there are any concerns, and we're wanting to make sure we firm up the work that we do and review those on a regular basis. We're also working jointly with the Children and Families Department to implement the Adolescent Public Health Service, and there is an element within that service that focuses on substance misuse. And then finally, there was an independent review conducted by Dame Carol Black, which is a national review that informed the development of a 10-year national drug strategy from harm to hope. And then that led to a requirement for all local systems to set up a combating drugs partnership. What we're aware of is that the focus of that work was solely focused on drugs, and it didn't have a lot of mention on alcohol, which was a concern for us, because the work that we do is around substance misuse, and they often go hand in hand. So the local direction of travel for that is to focus on substance misuse as a whole rather than solely on drugs. Also, the priorities within the strategy focus a lot around enforcement as well, and we're wanting to take more of a public health approach to the work that we do. And the other element that we want to take forward with that is to, rather than creating new partnerships, new groups, new boards, we want to utilise what we've got. I'm confident that we've got quite a strong partnership set up already, and structures in place, and governance measures and governance processes in place. So I don't want to set up whole new partnerships and then disengage those that we've got already. That's it from me.
Okay, thank you very much. Right, we've got some hands going up. Bessie, do you want to go first, then Mr. Hills, then Mr. Harrison?
You mentioned schools. So I used to teach at Loughborough University, and first year students, first times away from home, big issues with alcohol. And I just wonder, I mean,
Yeah, we're already part of the Freshers Week plans as well. So we do that on a rolling basis jointly with Turning Point and some of our internal staff as well, just to put out the messages.
And a bit of a follow on from me, and it's probably a further question for Josh. Now, I guess the other reflection would be alcohol in young people is still an issue, but it's not quite the issue it was when I was a kid. So, and I'll make it a question. Is it worthwhile reflecting on kind of trends in alcohol misuse in younger people? Because alcohol, to my mind, isn't as big an issue as it used to be when I was a lad. All right, that could have been just me.
Yeah, we're not seeing the increasing trend in young people as we have done in adults. What we're seeing is becoming more of a prominent issue in younger people is vaping, which is outside of the service, but it's work that we do need to look into. And actually, Trading Standards team did say to us that that's where they receive a lot of the complaints. It's underage sales around vaping rather than alcohol.
You're just about to get a follow-on question from Mr. Hills on that very subject. So, do you want to go next in that case?
I was going to ask something different first, but we can go to vaping first. Absolutely, like I said, it's not quite within the remit of this report, is it, vaping? But I thought it was a very, very interesting thing. I was going to ask, what the county is doing within your team to look at vaping. Maybe that's a question for another time. Just to illustrate the point, I did some research recently. An ALF bar, which is the most popular one, they come in highlighters. I had to explain to some of the members what an ALF bar was, but it has the same nicotine as 50 cigarettes. Cost us £4. You get 600 puffs out of it, apparently. So I think, I see it massively, in younger family members, friends. I was at Reading Festival this weekend and all the young kids were doing it there. So I think it's definitely on the rise. I think we probably need to discuss that in another meeting.
No, I can come in on that if you want. I mean, I absolutely agree. It's a conversation we've had with Mrs. Richardson, and our lead member's not here today because she's away. But she's very interested in that. I think it's fair to say you'll be aware that, for a long time, I'll have always said consistently, if you're a smoker, switch to vaping because it can't possibly do you any more harm than smoking tobacco. If you weren't a smoker, why would you ever embark on vaping? But there's obviously, to my mind, a concentrated effort by the industry to start encouraging young people, and that Elf Bar stuff, I've seen them in the local vape shop, the way it's advertised, almost like the old kind of Camel cigarette advertising campaigns. There is a suspicion that that's around sort of, gateway drug stuff. So if you get them onto vaping, they then move on, given the nicotine that's in there, into something like that. It's a conversation I had with Gary Connors in Trading Standards on Friday, and it'll touch back on alcohol. It's an interesting one. It needs to be clear about what we can use the public health grant for and what we can't. So underage test purchases for alcohol is, the responsibility is Trading Standards, it's general fund, because that's about enforcing underage sales. But there is stuff around vaping, as I said to him, if we can work that around illicit vapes, obviously Elf is legal, but some of the stuff, some of the counterfeit stuff is very, very high nicotine. So I've probably got a way of funding some work in Trading Standards, which we can then try and work around the educational part to just try and do a bit more through the Healthy Schools programme and vaping to inform kids of be careful what you're getting into. So more than happy to come back on that one on a future date when we hopefully add a bit of meat to the bones of the conversation with my Trading Standards colleagues.
It sounds like really productive work. I was going to say, Joshua, as well, I try and slip in my experience. I work as a dentist, so I try and get that into every meeting. I think this is the point where I'm going to get it in now. I always have discussions about alcohol and cigarette use or tobacco use with my patients. And I've noticed lately, patients get diagnosed with various types of cancer, lung cancer, mouth cancer. They suddenly say to me, "Oh, I've stopped smoking now." And I also think, well, it's a bit late, isn't it now? So I was really interested to hear about this Turning Point non-invasive assessment you can do of the liver health. My question is, how early on can you do it? Because I feel like if we could show the signs of change before symptoms have actually occurred, I think patients will really respond to that. So how early on can you do it? How expensive is it? You said you can do it kind of an outpatient, doesn't have to be in hospital settings or anywhere like that. And how many patients can you see a day doing this?
At the moment, because it's a pilot service, we don't know the volume of people we'll see, but we'll grow it based on what we see. We funded it as a 3-year pilot with a view to kind of keep an eye and evaluate and see the impact it's having. In terms of numbers that can be seen, again, it depends on the workforce that are able to commit themselves, and that depends on the funding that we can allocate to this. As it's a pilot, we're using a sort of 3-year pot of funding that we've got. So we'd need to look at if that's beneficial in terms of funding over something else in the future. So I wouldn't be able to give you numbers. And in terms of how soon you can do it, that I'm not sure of. I'd have to do some more work to look into that. But it can be done a lot earlier than the physical symptoms, and that's the benefit of it. And because it can be done as an outreach rather than sort of having a full sort of clinic or radiology department in place, it's just easier to do as a mobile provision.
Okay, thank you very much. Mr. Hills, you never ever mentioned you've been a dentist. You just slipped that one in there. You need to mention it more often. Mr. Harrison, are you a dentist by any chance, Mr. Harrison? No, you're not.
No.
Okay.
No. Thank you, Mr. Chairman. I'd like to take you back to children. I've had lots of experience in primary schools. I taught judo for many years, up to pre-pandemic. And I was at the forefront of an organisation recently was dealing with knives. Children take knives into school in the bags. I was astounded when I asked the question and could see the results. When you look at 10 and 11 and 12-year-olds, wow, they're really, it's nothing like what you'd see 20, 30 years ago primary. And I think, you know, if they're doing that sort of thing, and this organisation I'm involved with only went to secondary school. Now all of a sudden they say, yeah, we've got to get into where it really begins at the beginning. Because if children start just trying to do things, and these young children from say 10, 12, 13, 14 over on parks having a can of beer or something, it's just the start of the thing. And it'd probably need a fairly good programme going. But there is this programme that's running, the county council's involved with in schools, and I've been sort of pushing the knife bit, and they want to do it, and I've been to watch them do their bits, and I want to go and watch them deal now, and it's an amazing, absolutely amazing, with 4 different classrooms all full, and you're wandering in and out, and there's pupils allocated, you're in charge, and they're doing things and it is a first-class programme. If you could sort of line up and get involved with that, because if someone's delivering something, why invent the wheel again? And the whole thing I'm trying to explain is there is an organisation that you could probably work with if they had the right sort of background and they need training and support, like I gave them reference what I was able to do for them. Probably to be another way, because it's the very young, you've got to really catch them really young. And then you can sort of create that wellness within them in the minds that can be bad. So happy to help you if you need any more information on that. Thank you.
Thank you, that's really helpful. We do have Turning Point, we do have a specific young people's offer within that service, because it's not about, that's particularly for children and young people, it's not about waiting for them to have an issue with alcohol or any other substance misuse. So they have a tiered offer, which is the universal prevention, universal offer in schools, where they go out and do lots of talks, and they have the next stage up where they do group work sessions if there are specific vulnerable individuals in that school, and then they offer one-to-ones as well if they then pick out specific individuals who require that support. So they have got, I feel like they've got a really robust young people's offer where it's not just waiting for the treatment to happen, it's that the offer underneath, and a lot of that is around education and awareness. So, yeah.
And also it's about capturing data, because that's what we were talking about earlier on. How many young people would you know have been involved with alcohol? You could even broaden it up because you're talking of drugs, and try to build evidential stuff so people can actually, because you know we all talk, but I mean once you start to get the numbers flowing and you understand and you can watch the ages, then it will really, and if you've got a machine running, well then I would just urge you to sort of talk about adding in more statistics so you've got real facts to be, and it would help you with funding going forward if you can prove what you're doing is having an impact. Thank you.
I think with the service, the new service starting in April of this year, that's the plan, that we'd grow that information. It's a different service to what we've had before, so I am hoping we'll be better in terms of a data point of view. But yeah, any join up with anything that's already out there, we don't want to hammer it at schools with lots of different offers of the same thing. We want to make sure that the offer's coherent and joined up, because I know Leicestershire Police also provide offer in school, and I think I've provided some data in the report as to the number of young people they target. But I just want to make sure it's not sort of fragmented and schools are feeling like they're getting too many people coming at them from different angles as well.
And I guess just from me on data, I'm just mindful of Josh's early comments in the paper about, to some extent, we're awash, and no pun intended, on data about alcohol, the consumption of alcohol and the rest of it. Key standout stat for me is we know we're only reaching 1 in 5 dependent drinkers with the current service. So there is something about capturing the data of interventions like the liver one, which is well meant. I think really for me, it's just making certain people aware of just how pervasive the issue is and how good the service is on a relatively limited budget. So there's always a selling job to do, which data backs it up, but equally sometimes you can chase the data and then really need to do the selling bit too.
Thank you very much. Mr. King.
Thanks, Chairman. Well, I'd agree with Mr. Harrison. I think some data and some illustrations of some of the data trends here in this report would have been quite helpful. But I'm a little bit confused by this report, not because I don't understand it, but just because we've got a substance misuse strategy, which presumably is all substance misuse, but we're actually trying to talk about alcohol and the role of trading standards in preventing alcohol misuse, which I kind of get, but also in a weird way I don't get, because actually licensing authorities have got a much bigger role to play in controlling the sale of alcohol both on and off premises, and that's hardly touched on in this report. I appreciate that's not a county council function, but it is nonetheless a very important part of the equation. And I think there is probably more that can be done with licensing authorities to and also with licensed premises themselves to so if they are having, shall we say, an alcohol promotion activity, I'm sure that never happens in Loughborough, Mr. Chairman, or bits of Leicester, or even Market Harborough. I think that's something where perhaps some work needs to be done with licensees about. A long time ago, I actually did work in a pub and a hotel, so serving drinks to people who are clearly intoxicated. As a somebody who works behind the bar, you have a responsibility. There is a responsibility, as it used to be, to not serve them any more drinks. And so that is, I think, there's an education with the trade issue maybe that needs to be relooked at, because I've not been hearing that message coming through recently. But I think it is important, because obviously if someone does become an alcoholic, it basically it massively affects them, and fundamentally it alters their life, and there's no question of that, and it's a costly problem for society, wider society. So I think whilst it's very useful to know what the impact, the cost or the economic burden of alcohol is across the UK, it'd be quite useful to know what the economic burden is for Leicestershire. So again, there's kind of a bit of, I appreciate we might not have that, but just to kind of guesstimate then. So some of the data is very specific for us, and some of it is just very national data, which is interesting, but really our interest is Leicestershire, and it'd be just really useful to kind of, can we have it all on the same thing, so to speak, because then it'd make it easier to understand what difference this strategy is actually having. And finally, Chairman, just to pick up a point which kind of emerged during the kind of out of the lockdown situation, particularly with younger people, is the role of older people in. So when there was the end of lockdown, various lockdown bits, there were what were called public gatherings where particularly younger people, suddenly there were what I described as parties in the park that used to happen, and people would turn up with cases of very strong alcohol or bottles of spirits and hand it out to young people. I'm talking about hundreds. This is something it certainly happened in South Leicester, certainly in the Market Harbour area, which I represent. This was happening. I actually caught the police unawares. They weren't expecting this at all, because it was organised by these gadgets, by the social media system, and clearly there were actors involved who were feeding, if I can put it like that, literally feeding young people strong alcohol and maybe other substances as well. And very shortly there were young people, literally comatose on the ground, or very seriously ill, and that then required other services to get involved. So I think that was kind of a year or so ago, and it's moved a lot away from that because of the community safety partnership locally that worked on that. But I'm just wondering if that is also still prevalent and still happening, and whether this strategy, this work, is actually going to look at working with those other agencies to tackle that sort of binge drinking kind of grooming that effectively is going on of younger people to get them, and I'm talking like 13, 14, 15-year-olds, not people who could go into licensed premises, and it's a serious matter that people, and because there's other substances being peddled at these things. That's what I've been told. Thank you, Chair.
Just with the first point around the substance misuse versus the alcohol, when we do the work around this area, we do substance misuse, which includes alcohol and drugs, so it's combined. But the national work team seems to be quite divided, and they'll have an alcohol strategy and a drug strategy. But for us, it's hand in hand because of the link and because of the way the service works. Around alcohol licensing, yes, there is a lot more work that needs to be done, and that's one of the things that we're wanting to do and strengthen in terms of the future developments. It's an area that we haven't had capacity to do as much as we would have liked, but that will involve the working with the partners, so the districts, etc., where some of that responsibility lies, and the work we want to do initially involves almost mapping the licensed premises with the sort of rates of crime and other factors to look at heat sort of maps and look at areas that can inform licensing decisions going forwards. It is a work in progress. We're very much in the early stages, but yeah, the focus has been on recommissioning the service, in all honesty, but that's where we want to go now that the service has gone live. And then regarding the data, yes, there is some national data and there is some local data in there. It's the data that I had. But we can extrapolate for future reports to be Leicestershire specific. But yes, it's the information where I could provide local information. I did. And then with regards to the binge drinking and the young people's behaviours around alcohol, that was the reason for us having that partnership approach with police, with districts around the community safety partnership group that's specifically around substance misuse. But we also link in closely with our district CSPs, and my team do a lot of work with them. They're working with them around the future priority setting for the new plans. And this is the local intel that we then need to work on with Turning Point, with Healthy Schools, with other areas of work that we do. But without that intel, we wouldn't. But that's where, again, we've developed a lot of close working relationships, and we're hoping that will only strengthen further.
Just to build on that one, I mean, it's been a long time actually since I've seen the alcohol licensing application come in, but I know we're a statutory sort of consultee. It's Deborah in your team, isn't it? Who still does it? Kirsty that does it now. From memory, last time I looked, there's an element of kind of it comes in, you haven't got an awful lot to say no on. But I think what Joshna describes and your question, Mr. King's absolutely right. There is something for me about, from a public health point of view, you'd want the overlay of data with assaults, with the police data. You would want to be talking to district licensing authorities about the concentration of alcohol outlets in a particular area. And it was a plug for, and again, correct me if I'm wrong, Joshna, at the last strategic partnership board exec meeting, which I've just started sitting on. I know you've been involved for some time. Some of these sort of overlapping of data and the way it's presented by the Violence Reduction Network was absolutely great. Now, I was more looking at that, as Josh has said, with a view towards drugs because of the From Harm to Hope, the National Drugs Reduction Strategy. But actually, it feels like elsewhere outside of public health, although we've had quite a lot of input into that kind of data sharing and building up the map to enable you to then take the data away was beginning to get there. So I don't know at what stage we could bring the SPB stuff here, just to basically show this is the kind of dashboard tools we've got, but it might be something we want to consider. Because you're absolutely right, that's where I would like to get to next.
Okay, thank you very much. Thank you very much, Josna. Thank you very much, Mike. I think we've run out of questions at that point, so that's a good moment to stop. So thank you very much for answering the questions from everyone. Item 11, which is date of next meeting. The next meeting is scheduled to be the 2nd of November 2022. And on to item 12, any other business? And there are no items of any other business, so I am declaring the meeting closed. Thank you very much. Thank you.